Thank you. So my name is Ivan Somondi. I'm currently serving as a postdoctoral research scientist at APHRC, and I will be doing this presentation on behalf of APHRC team. I think they are all here in the room. And if you don't know them, I will request them in a second to just raise their hand up so that we know where they are. In case of any questions, they can ask. That's okay. So this presentation is centered on modeling the impact of educational campaigns and especially involvement on women's fertility preferences and pregnancy outcomes in Nairobi, Kenya. And as you all know, fertility is a key factor influencing the demographic composition of population, and the trends differ significantly across different regions. And due to this variation, many countries, including Kenya, have implemented various programs to improve maternal health and child health. And more particularly in Kenya, there was a rollout of a Linda Mama program, which set out a target of about 60% prevalence on contraceptive use by 2030. And despite these programs, there have been significant disparities in maternal and child health. And based on these disparities, we conceived this project to try to test out some interventions that can be implemented by the government and policy makers to try to see if we're able to meet the targets set out for the 2030. So these are some of the questions that we intended to answer. First, to examine and extend the existing family planning simulator, which was developed by O'Brien and co-authors, and develop a similar model motivated by our local data from NU HDSS, and then assess the impact of educational campaigns and male involvement on fertility preferences and contraceptive use. And we know family planning options and fertility preferences in many regions has always been a preserve of the female, and we really want to bring on board our males and see if we are able to improve on the maternal health and child health if they are brought on board. And then number 3, we'll be able to get results from this project to guide the development of targeted policies and intervention regarding family planning. And the last one, to try to find out the patterns and trends in births, deaths that include maternal and infant deaths, and the overall planning dynamics in urban slums in Nairobi. To start on this, as mentioned, it was motivated by our local data from the NU HDSS, and the power of HDSS normally lies in its ability to provide very high quality longitudinal data set. And one such HDSS is the NU HDSS in Nairobi, which is collected, which collects data from 2 slums in Nairobi. That's called Goch slum, and the view and the slums at the top there, and the map down there is the map of Nairobi. So this was launched in 2002 and has collected data over that period of time. But the module for family planning and pregnancy outcomes was started in 2012 all the way to 2015 when it stopped. And there were about 756 women who were interviewed during that time. So to answer our question first, we extended the other model that was developed by O'Brien and co-authors, and we split ours into 3 modules. The first one is the main module, which is actually the implementation module, capturing all the dynamics of the NUHDSS about the women, such as the age, the location where they are, the sexual debut, pregnancy status, and the rest. And then the second module, there is the FP module, the family planning module, which provides all the choices about contraception. And the last module is the pregnancy module, which provides all the outcomes related to pregnancy. So these are the interventions that we intended to implement in order to answer our questions and see if we are able to achieve the objective set out in the Vision 2030 for achieving 60% prevalence on modern contraceptive. And the first one is the educational campaigns about health promotions, responsible parenthood, and birth spacing. And then second intervention is the involvement of male about family planning discussions and fertility preferences, and then the combination of the 2, male involvement in the campaigns. And in these interventions, We check the effect size and the impact of these interventions on women preferences. So in this work, we have implemented one intervention, and that is the campaigns, educational campaigns, which first we have to calibrate this model using the data to get the baseline of the prevalence and other outcomes. And then we varied our campaigns based on coverage from 10% to about 60%. And anything beyond 60% was not giving any impact. So it means 60% is the maximum level of campaign coverage that can be achieved with this model. So from those, that's the calibration. We actually project those results at 60%, and we're able to see there is an improvement of prevalence of either use slightly, and there is also improvement in other outcomes based on that campaign. And then after obtaining the optimal campaign level, we looked at the switching of contraceptive use by women, and this was aggregated by age and followed after 1 year. And this, as first example here, we realized that a majority of the young women, that is 15 to 19 years, switching from these other types of contraceptive to no use at all. So that means that discontinuing that. You can see I have 1 minute. And the same applies to that age group 25, and that was the last one, that is above, those are above 35 years of age. So the key takeaways from our this finding, one, the coverage above 6% showed no impact at all, and the campaigns actually have great significance in the change of contraceptives used by women, and even though it gives us high fluctuations in both maternal and child mortality. And these results are actually very much important for policy implication. One of them, there is need to continue with the campaigns to maintain and improve the use of contraception as well as maternal health. So what are these are some of the conclusions we have. This work was actually made possible by a longitudinal survey conducted by NUHDSS. And this really provides high quality data for calibrating such models, which is really good. And campaigns about fertility preferences really improves family planning outcomes in urban slums, which are actually underprivileged. So the next steps, it is frozen. So our next steps are one, because we have so many interventions that we want to implement, and we already implemented one. We are going to see if the next stage we will be able to implement the implications of involving a male into decision making, and this is dependent on the one the new EPISIM, this is EPISIM 2.0, which actually was just we talked about recently. We're going to see how we're going to apply that to implement that, and then of course perform the experimental analysis. And lastly, look at also the effect of health facilities on improving maternal health. I can't end without appreciating all this team. First, the team at FHRC for the support, the team led by Michelle from IDM. It was really a great insight this year, learning about agent-based modeling and how it can be applied in informing so many things like policy. And then our partners in this training, SEMA, Strathmore University, and the Jomo Kenyatta University. Thank you so much for listening. So the team at the PHRC, are you ready to answer the questions?
So I wonder if you have any insight into why that 15 to 19 age group is switching so much from contraceptive to no contraceptive? Like, is this like a behavioral difference in sexual activity? Is this a generational shift in opinions about contraceptives? I wonder if you have insight into that.
Thank you. That's a very good question. I think there could be so many factors that is influencing all these changes. Could be one, early marriages at that age. Two, it could also be a fact that because of early marriages, they also are trying to find out if they are able to get kids, plan for that. There's actually many factors that can influence that.